Hey everybody, welcome back to my ankle skills check video. Today we're going to be taking a look at my lovely assistant's ankle here. She's got some complaints of stiffness and pain, so we're going to go through good thorough evaluation, figure out what's going on. First things first though, I want to do a joint play assessment of her ankle. We're going to start off with the talocrural joint between the crux here and her talus. So for all good joint play assessments, you want to start in the loose packed position of the joint, which in this case is going to be subtalar neutral with 10 degrees of plantar flexion. So to find subtalar neutral, you're going to go ahead, get your fingers on the domes of the talus, and you're going to look for where you find them equally distributed between your fingers, or equally prominent between your fingers. Next, for 10 degrees of plantar flexion, you're going to want to bring her foot up to 90. You can see the angle between the fibula and the base of the foot, looking at 90, and maintaining that 10 degree, or that subtalar neutral. We're going to let it fall at 10 degrees. From there, we're going to look at our joint play assessment. So, there's a couple components I want to look at. I want to look at the motion of the lateral malleolus. I'm going to come around here, get a good inferior force, looking for that posterior motion, feeling on the lateral side here. With my index finger for it moving back in my finger, moving very smoothly there. Next, we can take a look at traction. Getting a good pull directly perpendicular to the articulation there. We can also look at posterior and anterior glides. With your posterior glide relating to plantar flexion and your anterior glide relating to dorsiflexion. Come right on in here. In this case, I can push the crux back on a stationary ankle, or conversely, you can push the ankle back on a stationary crux to get an impression of the quality of motion and the ease of movement. Next, we're going to be taking a look at the subtalar joint in here, your talus and your calcaneus. So for that, it's going to be the same loose pack position. There's not a roller glide in this joint, but we want to get an idea of the motion in that. So bring it back to subtalar neutral with a little bit of a lovely background noise. It's going to be a distraction that's going to be inferior and posterior, about a 45-degree angle. So a good firm grip on the crux, a good firm grip on the calcaneus itself, and pulling down and away. You get an idea of the approximation of the surfaces there, good tractional force. So we could also look at the Chopard's joint or the loose Frank joint, but in this case, we're not going to be looking at those. Next, we're going to move on to some special tests. All right, so now we're going to be taking a look at some special tests of the ankle. First things first, we're going to do a compression or squeeze test for the ankle. It's going to happen right up here in the mid-shin area. And so what's going to happen is I'm going to compress on top or anteriorly or posteriorly, however you want to do that. But you're looking to bring the fibula and the tibia together to approximately to bow the distal malleoli. And so when you do that, the syndesmosis that connects them is going to be put under tension, and if the patient has a torn syndesmosis, a ruptured syndesmosis, or a partial tear also, they're going to experience pain, discomfort, some notable symptoms. So in this case, I'm going to go for a posterior grip here, do a bit of compression. And when you actually compress these, you can see the malleoli move apart from each other. You get a little bit of space that shows up between them, more so than there normally is, of course. And any pain or discomfort with that?
No.
Sounds good. All right, so that's going to be a negative test in this case, but that is how you would go ahead and perform a compression test there. Next, we're going to be looking at fibular translation. So for that, you want to put your patient's leg in an internally rotated position. You're going to want to get a good wide grip around the fibular head. So one of the issues that you can run into is you're looking at motion, but also pain provocation. If you use a very pinpoint grip, a finger grip like this, you're going to have a okay grip on the fibular head, but you're going to get false positives of pain just due to the amount of force straight on such a bony structure. So with the internal rotation and the wide grip around the edge of it, pushing that posteriorly, this is going to be a little bit similar to your assessment of joint motion that you did initially, but in this case, we're looking more for quantity and symptom reproduction. So, obviously, for all special tests, you're going to want to compare bilaterally, both to understand the results that you're getting and to see if there's more going on than you may have initially thought. But as far as fibular translation testing goes, that's going to be it for looking at it posteriorly. You can also look at it anteriorly. Body mechanics is something important to think about there, so get everything appropriately positioned and blocking the motion as it comes to you. You can feel with either hand's fingers, but as I said, this being a pain provocation test and a gross motion test, you're not as much looking specifically for the palpable motion with your fingers. So next, we're going to take a look at the anterior draw test. Similar to the knee, where you perform an anterior draw, this is going to look at the ligamentous structure of the anterior. This is going to be looking, if you had a syndesmosis rupture, if you had just a gross loss of stabilization, especially on the anterior aspect of the talocrural joint, an anterior translation is going to take place when you have this force going through. So you can do this a couple different ways. You could do it with the leg bent, the foot on the table, keeping the foot still and pressing the tibia and fibula posterior to get that motion in a more closed chain look. I like to work more in open chain. It lets me feel like I have a better grip on the patient's structures and be a little bit more in control. In this case, you're looking for pain and gross motion. So I'm going to stabilize the patient's hand here on my femur with my inferior hand and my superior hand. Nice perpendicular joint force. Just going to apply good posterior motion over the top. I can feel with either thumb or with my two fingers on my left hand here. They're just inferior to the medial malleolus, so I can get an impression of joint motion. And that's going to be a negative. Of course, you want to compare bilaterally, but this would be something that I wouldn't expect to see on the asymptomatic side, unless they were having bilateral pain where one's a little bit more than the other. Next, we're going to look at talar tilt test. That's going to be for both inversion and eversion, depending on the way that you do it. You want to really focus on having good perpendicular forces for the angle that you're coming at. Let's modify our camera position here a little bit so that it can be seen a little bit better. This is going to be looking at, when you do inversion, you're going to be looking at the lateral structures. When you do eversion, you're going to be looking at the medial structures, as those are going to be the things that you are putting tension on. So I'll start off with a inversion motion. That's going to be stretching the lateral structures, and I'm looking for pain or maybe excess motion in this case. If they had grossly excess motion compared to the other ankle, it could be indicative of some ruptures and tears. Do the medial side, good blocking, a good grip on the calcaneus for this one, for both of them really, to really assure that you are doing the motion that you say you're doing. And this from the medial side here is going to be looking at a lot of different structures, your deltoid ligament in here. But that's going to be really good for getting an idea of both pain provocation for sensitive structures, for maybe an ankle roll, or for maybe excess motion that may be an issue. So next, the Thompson test. Really good for looking at an Achilles tendon rupture. In this case, normally you would have a patient do it in prone. You can do it in supine. The positioning isn't as much an issue as recognizing the plantar motion that is being produced. So in supine, where a patient is passively in plantar flexion, or where the gravity is pulling them more towards dorsal flexion, you have the benefit of a visible motion that comes through very clearly. In supine, if the patient wasn't able to lay prone, supine, you're going to have to modify appropriately. And in this case, I find it easy to really produce a gentle dorsiflexion force. And to perform the test, you're going to come up here on the posterior calf musculature, the triceps surae muscle group, really. And you're looking for a plantar flexion production when you squeeze the calf. So what I'm looking for with the knee straight here is the force production. You can actually see a little bit of plantar flexion motion there that happens when I squeeze the calf. As I contract this muscle up here manually, what's going to happen is the foot is going to push in the plantar aspect. So this test is actually really good. It's both specific and sensitive, over 90% for looking at a complete rupture of the Achilles tendon. Partial tears, you're going to get pain provocation as far as production with the contraction, the tension that's being placed here, especially if you do a resistive force, as that's going to put additional stress on here as opposed to the passive motion. Next, we're going to take a look at an assessment for subtalar neutral. I went into this a little bit earlier, but you're going to palpate out the domes of the talus just anterior to the talocrural joint, and you can invert to find the lateral, you can evert to find the medial, and when you feel an equal representation of the two, that is going to be your positioning for subtalar neutral. Next, I'm going to take a look at some testing for a Morton's neuroma, an interdigital neuroma test, also known as the squeeze test sometimes. It has a variety of names, but in the case of a Morton's neuroma, it's going to be a enlarged nerve that runs between the metatarsals, so most commonly showing up around the third metatarsal. And with the nerve running between those, you're looking to do a compression force. So in this case, I have my hands wrapping around both the bottom and the top, the dorsum and the plantar aspect of the foot, and you're bringing them into line and compressing them together. What you're looking for is pain provocation, especially in this case, and it should be an exacerbation of the patient's symptoms. It's going to be the thing that is causing them the pain normally when they're walking or whatever aspect to bring it up. A good compression through the distal surface of the foot to really approximate those surfaces. And so when you get a positive test there, in general, you can go through and do a shear motion between the distal heads of the metatarsals to more specifically locate the area of pain. So you can start with the first on the second. If that's negative, you can go to the second to the third. And so, I mean, even if I move the second and the third, I'm still getting compression and joint motion based on my finger placement into the area between the third and the fourth, and a little bit in the fourth to the fifth. So you have the need to go through all of the metatarsals to really pin down exactly where it is. There's a couple of tests you can do, like you can reproduce Tinel's sign between the toes on the plantar aspect, which when appropriately done will also show you the sensitivity that will be present in a Morton's neuroma. We're also going to look at Tinel's sign. In fact, in this case, we're going to look at it medially on the ankle, right here over the nerve and vascular supply. So Tinel's sign, you're going to do 4 to 5 quick taps over the nerve supply. So first, you can palpate out your vascular supply, especially in this location because the nerve, tendon, and vasculature are also close together. Once you have located your vasculature, you're going to do 4 to 5 taps. They need to be forceful, but not exaggeratedly forceful. You're not trying to injure the person's nerve by doing the test. That's a bit counterproductive. So, and what you're looking for is going to be a reproduction of symptoms distally down the extremity. So I performed it specifically just posterior to the medial malleolus. You could perform this at the knee or higher up. Tinel's sign is more of a concept than a specific location. So it's the application of that concept in different places. But that is a good functional way to also use screening for neurological conditions, especially where you have compression symptoms or things like that. like in tarsal tunnel. Next, we're going to take a look at ankle measuring for swelling. I'm going to sneak on in here and get my trusty tape measure. I'm going to start off on, I'm going to use centimeters for metric accuracy. You're going to start off on the anterior aspect, coming medially, just distal to the navicular. Wrap around the bottom, coming proximal to the proximal head of the fifth metatarsal. Then you're going to wrap medially behind and inferior to the medial malleolus. You're going to come inferiorly to the lateral malleolus as well. And so you are looking for the number that is produced at the center of the cross that is formed. Let me get a better picture of that. You're looking at that intersection there. In this case, it's going to be 6.5 here. And so that's 6.5, of course, coming after 40. So that shows a ankle volume of 46.5 when measured between all this. Another important aspect is going to be that you don't start at the end of your measuring tape, if you can see that, but you start your measurement at the 0 on your measurement tape, because otherwise you're going to be adding 2.5 centimeters to your measurement, which is going to make it difficult to be consistent if you realize your mistake later down the line. After this, I'm going to take a look at Hoffman's sign. So in this case, that's going to be the patient in bed, can be flexed. You can use a bolster, you could use manual resistance. But you want to be able to also perform the second aspect, which is going to be a overpressure into dorsiflexion. And so Hoffman's sign can be used in conjunction with Wells criteria to look for DVT. Obviously, both is better than just one. So there's great value in not simply relying on Hoffman's sign, but as you apply a dorsiflexion force with the knee bent and you stretch the posterior musculature of the calf, you're looking for the production of pain in the posterior calf that not only reproduces their symptoms, but also is not a stretch pain. The stretch pain can be normal people tight calves, but obviously a DVT is much more severe than having a tight calf. Finally, we're going to take a look at auto ankle rules. When you use them appropriately, they are 98% sensitive, so very good at ruling out an ankle fracture, a true negative for an ankle fracture, which is what we care about. You want to know if you need to take an x-ray of a broken ankle, and you need to take an x-ray of a broken ankle. So auto ankle rules are a very, very effective way to go about that. There's two different aspects of it. You have a set for midfoot pain and a set for ankle pain. So for ankle pain, first off, you're going to be looking for tenderness to palpation, or in this case, point tenderness at the posterior edge of the distal 6 centimeters or tip of the lateral malleolus. So in palpation, right around here. Do you have any point tenderness right here? Is this hurt? Okay, excellent. Next, you're going to be looking at the same thing for the medial malleolus, point tenderness or a reproduction of pain at the distal edge and posterior edge of the medial malleolus. I'm doing the exact same thing just on the medial side. Any pain there? No. Okay, excellent. And this third step, which is shared between the two auto ankle rule sets, is going to be an inability to bear weight immediately after the injury, and both immediately after the injury and when they show up in the emergency department with a potential ankle break. So that's looking at 4 steps. If they can bear weight for 4 steps, and that's going to be a negative. For the sake of this video, are you able to walk 4 steps?
Yes.
Excellent. Okay, so that's the ankle taken care of. Next, we can look at the midfoot complaint of pain she has. So in this case, we're going to go ahead and look for point tenderness at the base of the 5th metatarsal. It's going to be right here for her. Do you have any pain, tenderness, to palpation, or movement right here?
No.
Excellent. Next, we're going to be looking at the navicular bone, point tenderness at the navicular on the medial side here. So, do you have any pain, tenderness when I'm touching your bone here?
No.
Excellent. And of course, third is going to be the same idea of an inability to bear weight for 4 steps, both immediately after injury and when they arrive in the emergency department. So that finishes up special tests in supine or laying, but non-weight bearing specifically. Next, we're going to move into some special tests and some functional testing that happens in standing. All right, so now we're going to take a look at 2 special tests to be done in standing. So the marking for this first one, the Feisline test, can be done in standing, supine, prone, whatever position you can get at the foot easily. To take care of this, you're going to need to palpate the distal head of the first metatarsal. You're going to want to palpate the navicular, and you're going to palpate the distal point of the medial malleolus. This is going to tell us about the positioning of the navicular bone in relation to them. It's called the Feisline because when you connect the distal metatarsal, the navicular, and the medial malleolus in a line, you get a visual representation of the angle there, and so you can see the actual drop that occurs between them. In this case, you can use a goniometer or other appropriate device to measure that angle. You measure it in subtalar neutral, and then you can go. So I want you to take your weight off this foot so I can move around a little bit. There we go. So get a hand of those domes. Right there. And then with a non-tandem stance, you want to go ahead. So in this case, I'm going to do it tandem so you can see. But you would have the patients in a stance that's not tandem, and you have them put their weight back on this foot, and you look for a change in the angle here. So potential issue you could see with this is because the angle is on the skin. Hopefully you can see that pretty well. If the angle's on the skin movement can be a little lax around the actual movement of the bone structure. It has to go through a couple different things to actually get there. Next, we can take a look at the navicular drop test. So it's going to be about the same as the Feisline. You use similar landmark, and so it's pretty well done afterwards. You take a look in subtalar neutral with my second lovely assistant here, at the elevation. There you go, good girl. The elevation of the navicular. So go ahead and take your weight off this foot again. There we go. So I need it on the ground. Hey, Freya, good girl. You can mark the elevation of the navicular on a firm surface, such as this lovely photograph I have sitting around, and then put your weight back on this foot. You look for the decrease in height that occurs, the approximation between it and the ground, and you can remark that. And so that gives you information about the amount of drop occurring at the navicular, the amount of arch loss that happens during weight bearing. It's a good, easily repeatable measure that you can use, and just by simply keeping track of the cards, especially with the navicular drop test, you can not only compare to the contralateral site to get an impression of whether it's a single foot issue, but you can also go ahead and keep track of progression of arch stability or maybe regression of arch stability over time. All right, finally, we're going to take a look at some functional testing. So for this, I'm going to be doing 2 things. First, a squat. Second, looking at your unilateral stance. In this case, got a good side angle so I can see any deviations. But of course, you want to look from all different angles of the body. You want to look from side, front, back, the contralateral side. Really get a full impression of what's going on. So can you go ahead and squat down for me as low as you can? Okay, and come back up. So in the course of that, you're looking systematically, either top down or bottom up, but you're looking at the ankles for inversion, eversion motion. You're looking at the knees for tracking straight to the sides, in. You're looking at the hips for rotational movement. You're going to be looking also at the pelvis for an anterior-posterior rotation, the lumbar spine for any kind of curvature that may show up. But as far as for foot pain, reproduction, or lower extremity issues, you're going to be looking especially at any kind of internal external deviation at the ankle or knee, inversion, eversion, and limb rotation that show up, along with any pain reproduction. That's a very big one that you want to be looking at. Next, we're going to do some unilateral stance. So you can go ahead and put a hand on the fridge there to stabilize you. Excellent. And so I want you to stand on your right leg. And so you're looking at a couple of aspects of this. You're looking at the forefoot versus hind foot compensation, which in this case, her forefoot, very stable, hind foot, pretty stable. She's got a little bit of anterior and posterior shift going on over the ankle to stay stabilized, but standing in a unilateral stance, that's expected. She's got a very good straight calcaneus in the back and calcaneal tendon, along with a good stable arch still staying there. Her toes look stable and on the ground, and overall, maybe a little bit of posterior pelvic tilt going on, but a nice straight knee, contracting muscles, nothing that you wouldn't expect to see. So of course you're going to want to do this on the other side as well to get an impression of both. Most importantly, of course, the symptomatic side. You are going to want to take a good overall and holistic look at the differences between the legs, along with the compensations that are being made for balance in both the squat and the unilateral stance.